Recovery from valve surgery is dependent on at least three things. What valve lesion is that we're repairing or replacing, what the general condition is of the patient going in, and what the access trauma is that's performed in order to get there. So let's talk first about the valve. If we have a patient with aortic stenosis, let's think what that heart's doing. That heart is trying to squeeze against the blockage. And when I go in and release that blockage with a new valve by whatever means, or repair the old one, I've got a good strong heart banging away saying, "Phew, let's go." That's not always the case. If it's been neglected too long, that heart's going to have failed. But in general, those people's recovery is pretty quick because the heart is instantly better. Let's compare that to a mitral valve that's leaking. That ventricle is supposed to be pumping out through the aorta, but the mitral valve's leaking. So it may pump half of its volume out into that high pressure system to the body, and it may say, I'll just throw the other half out the back door because that's a low pressure system, no sweat. I can sit here and get fat and lazy and not very strong. That patient has a slower recovery because their heart has to have some time to strengthen over the course of that. That's an example of the lesion. What is the lesion that the patient is having? Which valve? Was it a leaking valve or a blocked valve? That goes on. The condition of the patient going in has a great deal to do with that. If someone has been up and about and walking a mile a day, they're going to bounce back pretty quickly. If they're on dialysis and weakened and in heart failure and have been on a ventilator struggling for, well, you know that that's a much more difficult recovery for them. It's going to take them some time. The third thing that influences recovery is the access trauma. Access trauma is what we refer to as the incisions or alterations we had to do with the chest wall of the blood vessels to gain access to the heart to place or repair the valve. Now, traditionally, that was done through a median sternotomy. And people were restricted because it takes a good 6 or 8 weeks for that bone to regain its strength. Some valve lesions can be repaired through smaller incisions, and those generally heal faster. There's a technological revolution going on in valve repair and replacement. It's led the way with aortic valve replacement, and it's coming with mitral valve repair and replacement. And that is to have innovative valves with newer manufacturing techniques that are compressible and can be placed within a catheter and delivered by going up your own blood vessel, most usually coming from your femoral artery at the top of your leg, though there are a couple other approaches. That usually goes by the name of TAVR. TAVR is a newer technique, but it is getting better rapidly. In the beginning, we only gave it to our riskiest patients, the ones we knew wouldn't live through a conventional operation. As we gain experience with the technique, as the manufacturing and the delivery mechanisms improve, that's expanding now, and it's going to continue to expand as time goes on. The promise of that is that the access trauma is less, and that patient will have a more rapid recovery, and indeed, that seems to be the case as we move forward.